Hi, I'm Dr. Joseph Merola, and I'm delighted to be sharing personalized care in psoriatic arthritis for this special IPC presentation. I am a dermatologist and rheumatologist in Boston at the Brigham and Women's Hospital and Harvard Medical School, and I run a center for psoriasis and psoriatic arthritis. These are my disclosures. And I think just for level setting, I think it's important to mention that our patients with psoriasis certainly are all at risk for developing psoriatic arthritis. About a third or so of those patients develop psoriatic arthritis, and the vast majority of those who go on to develop psoriatic arthritis start with skin disease. So they are in our offices as dermatologists, and we're really seeing that at-risk population. The conversion rate that's been quoted in at least one study is listed here, about 3% per year, or 15 to 20% in 5 years from Leahy-Edders group. And why does this matter? It matters that we are thinking about psoriatic arthritis because, again, it's one of the most common comorbidities, about a third of our patients. But also, if we're not screening and we're not thinking about psoriatic arthritis, then there's the potential that we're doing harm to our patients. And this study that's frequently quoted reminds us that a delay as brief as 6 months is associated with increased erosion, joint damage, functional disability. And so it's really important for us to be thinking about this comorbidity in our patients with psoriasis. And also, it's a reminder that we are potentially missing a large number of our patients. This study suggests that 41% or so of patients have undiagnosed psoriatic arthritis. So all that said, how do we make decisions? How do we personalize the approach to our patients who do have psoriatic arthritis? And we have a very short time together, only really a few minutes. So I have to do this at high level, but there are so many treatment options in 2021. How do we start to think about which treatment option we choose for which patient? How do we align with patients on their treatment goals around psoriatic arthritis? Obviously, the first step, again, is screening and understanding whether a patient has psoriatic arthritis, and then either owning the treatment of that through our options of therapy, as shown here, or partnering with a rheumatologist or colleague in rheumatology to think about getting patients to the best care for both their skin and joints. So the first line, I think, of thinking in personalizing the approach to psoriatic arthritis management is a domain-based approach. And this has been largely championed by groups like GRAPPA. And the idea here is to think about, well, which part of the disease, which flavor of the disease, if you will, does my patient have? Do they have peripheral arthritis? Do they have axial spine involvement? Do they have enthesitis or inflammation at tendon and ligament insertion points? Do they have dactylitis, that swollen digit? Of course, skin and nail disease, which we as dermatologists are going to be quite comfortable managing. At very high level, this is just a reminder that the GRAPPA group has some treatment guidelines that are built around this idea of which domain of disease a patient has. And so you can see here on the far left, and this is an update from previous GRAPPA guidelines that were just presented hot off the presses at EULAR 2021. It shows the domain of disease here on the left, for example, peripheral arthritis or axial disease, enthesitis, dactylitis, skin disease. They even included a few common comorbidities, for example, IBD and uveitis. Then thinking about where the recommendations were strong for certain therapies, were conditional, either for or against. And so this is one framework within which to think about personalizing care. Now, this is a construct of my own, built a little bit around this framework of domain of disease of involvement shown across the top, as well as at least one major comorbidity, IBD, listed here. And then thinking a little bit about where do we have either head-to-head data or clinical understanding of how these are used relative to each other with regard to efficacy in these different domains. And again, in the interest of time, I can't go through this in great detail, but I will point out a few highlights. For example, the fact that we have in the biologic and systemic oral small molecule arena, from say apremilast down on this list, a variety of data, including head-to-head data in the skin that give us some idea of where patients might fall with their experience, depending perhaps on baseline severity of disease. We also have information about peripheral arthritis. We have some head-to-head data there looking at ACR20 results, for example, comparing IL-17 data and anti-TNF data. And then in the axial compartment, this is one I like to highlight because it's a place where we have to understand that not all of our therapies work the same. We have, for example, some studies suggesting that IL-12/23 inhibitors do not work in the spine or in axial disease. Whereas we have good data that anti-TNF drugs do work in that space. We have IL-17 data that they do work in that space. And in fact, even so much that for secukinumab, there is a dedicated axial psoriatic arthritis study, not just extrapolating from ankylosing spondylitis to help us understand how our patients might behave with these therapies. Similarly, data for dactylitis, enthesitis, and then variable data around certain comorbidities, which I'll come to next. And so, again, just in the interest of the short time we have, I'd like to highlight that thinking about a domain-based approach helps us with the framework for a personalized approach to psoriatic arthritis in our patients with psoriasis and psoriatic arthritis. So comorbidities are sort of the second layer. So if the first layer is domain of disease, I think the second layer is thinking about the patient in a more global sense. And we know that there are a large number of comorbidities and co-prevalent diseases among patients with psoriatic disease. To that end, we have a variety of things to think about, whether it be concurrent metabolic syndrome features, whether it be fatty liver disease, whether it be a concurrent IBD, inflammatory bowel disease, inflammatory eye disease. In thinking about which will the next layer of treatment be, and what options do we have to discuss with our patients. So this is a busy slide, but again, just another framework through which to think about an approach from a comorbidity standpoint. So across the top, for example, there are a variety of mechanisms of action. And on the left, you can see a given comorbidity. So for example, having a discussion about methotrexate and a patient with fatty liver disease, there's reason for caution in that context. Thinking about, for example, perhaps anti-IL-17 therapy and a patient with active IBD, that might be reason for caution again. Whereas other places might align quite well. I mean, a patient who has, for example, inflammatory eye disease or uveitis, and use of a TNF where there may be already approval for an indication. So I think that's a little bit of the second layer of personalization and tailoring. And then to kind of take it together, I think we talked about domain of disease as a driver for personalization, considering those comorbidities, whether it's compatibility with the comorbidity or perhaps even aligning treatment around the comorbidity. We have, of course, the shared decision-making process around treatment goals with our patients. How severe is their disease, and how would they like to optimize therapy? How is it impacting their life? How aggressively do they want to treat those points? And the other thing to think about in psoriatic arthritis, which is perhaps a little bit different than psoriasis, is the potential for damage, the potential for functional loss over time. And so aligning around treatment goals is also thinking about long-term impact and disease modification. With patient preferences, of course, is it that the patient prefers an oral route of administration, an injectable medication, for example? What frequency are they comfortable with? Is it an injection 4 to 6 times a year? Is it an injection every other week that they're comfortable with? And then, of course, like so many of us, we have to, the true answer comes with access to what we can offer our patients. And this is just for a reminder, and then I'll wrap up. But just to say that another way that we're thinking about patients with psoriatic arthritis in the rheumatology clinic is about treat to target. So there are algorithms that exist, thinking about how do we get patients to low disease activity states, remission states, and keep them there. And that's based on composite measures such as low disease activity measures you may hear about, minimal disease activity, DAPSA, and others. These are points of data that you can look to extract from psoriatic arthritis trials when you're thinking about an approach to the patient with psoriatic arthritis, and both personalizing and optimizing care to that end. And with that, I will say that to get patients really optimized, we have to work collaboratively. So here we are as dermatologists treating their skin, but also working with rheumatologists potentially around more challenging psoriatic arthritis patients, and other members of the team to get patients to where they should be from a therapeutic standpoint. We have a combined clinics nonprofit to that end. If you're interested in some of those models, please check out this website. And I thank you for your attention, and certainly to the IPC for the invitation to speak.